the psychiatrist's role in management of patients with AIDS, and some alternatives to methadone maintenance for heroin addicts. On Audio Digest Psychiatry, Volume 23, Number 23. Charles K. Billings, Chairman of the Board of Regents, Southern Psychiatric Association, and Acting Chairman of the Department of Psychiatry, Oxnard Clinic, New Orleans, discusses the neuropsychiatric aspects of AIDS.
What the HIV does is to attack the T lymphocytes, a particular type of lymphocyte. T4 helper inducer cells are what these T lymphocytes actually are. And we won't go into the details of how they function, but basically it has to do with cell-mediated immunity. The progressive destruction of these T4 cells leads to a decrease in the total number of the T4 cells. Ordinarily, this runs about 400 to 1,200, and they drop down to less than 100. You get a reversal of the T4 helper to T8 suppressor ratio, which normally is 2 to 1, and that can drop down to even less than 0.1. A drop in the white blood cell count, often down to below 1,500, and then evidence of impaired cell-mediated immunity. And if you remember from med school, this is basically the delayed hypersensitivity reaction, what you have in skin anergy, and also what shows up in the formal diagnosis of AIDS itself is the appearance of opportunistic infections and malignant neoplasms as evidence that the protective function of this immune system has broken down and the body now is vulnerable to these things in ways that it never would have been before. Just a reminder that HIV infection is a spectrum. When a patient's initially infected with the virus, after about 6 weeks, they typically develop antibodies to the virus, and this is a stage that we call seropositivity. That is, they will test positive for one of the AIDS tests that we typically use to identify infection to this illness. Patients at this stage of infection are typically asymptomatic. There may be some mild upper respiratory symptoms when they're initially exposed to the virus, but usually these are not noticed as anything spectacular. And then the person develops antibodies, is seropositive, most importantly also is infectious. Even though the patient has no symptoms, often is unaware of the fact that they now are exposed to the virus, can still pass that virus along to other people. And then over time, patients will gradually progress upward in a series of stages to the ultimate peak, which is AIDS itself. Our current understanding of the progression, initially we thought it was just as simple as asymptomatic seropositivity to ARC and then to AIDS itself. We still have these 3 stages, but another one interposed that we'll get to here in just a moment. So infection's a spectrum. As I said, no physical symptoms at that lowest area of infection. Patients are infectious to other people even though they have no symptoms. The time from exposure to seroconversion, that is the presence of antibodies, is usually a few weeks, but in some rare cases it's been described as being up to 14 months. Those are very, very controversial, and in general I think we think of around 6 to 8 weeks as sufficient time for a person to have a positive test after they've been exposed to the virus. PGL, or persistent generalized lymphadenopathy, is another stage that some patients go through, and I should emphasize that not every patient goes through every single stage. Some patients may go from the stage of asymptomatic seropositivity right to AIDS itself. Others may go through PGL next and then AIDS, or on through ARC and so on. So there's a lot of variability in terms of the progression of the condition. But PGL is a condition where lymph nodes are enlarged to a centimeter or more, and these enlarged nodes are found in 2 or more non-contiguous extra-inguinal sites, so not in the inguinal area. The lymphadenopathy will persist for 3 months or longer, and there is no concurrent illness or other medications that would account for that lymph node enlargement. ARC stands for AIDS-related complex. This is another stage in the illness, is the one that's most often thought of as immediately preceding AIDS itself. Characteristics of ARC include weight loss, typically of 10 pounds or more, fever, night sweats, diarrhea, number of yeast infections, and then the symptoms persisting for 3 months or longer. So here again, the patient has gone through a stage typically of asymptomatic seropositivity, and of course with both PGL and ARC is evidence of some progression. And of course as the evidence of progression appears, the psychiatric symptoms begin to appear as well. AIDS itself then is finally diagnosed when a patient comes down with one of 2 things, either opportunistic infections or neoplasms, and our presumption is that these would not have occurred in an ordinary individual who had an intact immune system. So the breakdown of the immune system leaves the patient open for these sorts of infections. If we look at examples of the kinds of organisms under protozoa, we've got Pneumocystis carinii, which causes the very prevalent pneumonia in these patients. Toxoplasma causes brain abscesses very commonly. Under fungi, you've got Cryptococcus, and Candida. Cryptococcus very commonly causes meningitis in these individuals. Mycobacterium avium intracellulare, which is a somewhat exotic type of mycobacterium that can show up in these people, and a number of viruses, cytomegalovirus, herpes simplex, and others. So they can have a variety of infections with these organisms, and once that occurs, we say that they now have AIDS itself, no longer just HIV spectrum, but AIDS itself. Of course, pneumocystis carinii pneumonia is the most common AIDS diagnosis, with a majority of patients having that at some point in the course. Kaposi sarcoma was one of the first malignancies to be described in these people, but now a whole host of others have come along. Lots of lymphomas, leukemias, and other malignancies. Almost every one that's ever been described can occur in these individuals. The time from HIV infection, exposure, to the development of overt AIDS can be as short as 2 years, but has an average of about 8 years. What this means, of course, is that there are individuals out there who became infected early in the course of this epidemic who have yet to come down with overt AIDS itself. And it's possible that some of these individuals might, say, die from a car wreck rather than from AIDS. But the presumption is that most people at some point will progress on to the development of overt AIDS. But there's been lots of interest lately in things that we might do to slow that progression, things that have to do with managing stress, with nutrition, with exercise and diet, and so on, things that might strengthen the immune system as a way of slowing down this progression, and that's a very interesting area of research right now. Once AIDS itself is diagnosed, most individuals are dead within 2 years, less than 50% are alive after 1 year, and less than 5% are alive after 3 years. So once AIDS itself comes along, death seems to be around the corner for the vast majority of patients. Kaposi sarcoma may have a slightly more favorable prognosis than the pneumocystis carinii pneumonia, but that only means it's just a little bit longer before dying rather than actual survival of the illness. What do we know about epidemiology? And it's important for we psychiatrists to be very knowledgeable about epidemiology, because one of the major concerns that lots of our patients and families have is, how do you catch this illness, or how do you not catch it? What is safe? What's not safe? We know for sure that the infection comes from contact with bodily fluids, and this primarily means blood and semen. Now, the virus has been found in saliva, tears, and urine, but so far no certain documented case of transmission via these routes has been published. It's interesting that the intact epidermis provides a barrier to infection. So that means shaking hands with a person who's infected in no way confers any kind of risk whatsoever. But if you have a break in the intact epidermis, if you have a cut, an abrasion, that this may serve as an entryway for the virus into the system. And of course, this is one of the major reasons for the wearing of rubber gloves in individuals who have lots of contact with blood. But most importantly, this virus is not transmitted by casual contact. It's well known that several years now, following the family members of AIDS patients, of HIV-infected patients, where oftentimes family members will share toothbrushes, glasses, plates, all sorts of very intimate things in the home, that there's not been a documented case of a transmission to a family member. One somewhat controversial possible exception to this about a year ago, but that's the only possible exception that I'm aware of, and there's some aspects of that that would suggest that that may have come from another source. So casual contact is not the way you get it. So what blood and semen translates down to then, of course, is sexual activity, IV drug use, blood transfusions, organ transplantation, which includes, of course, skin transplantation, and then mother to infant, either in utero or through breast milk, and that's basically how you get it. We continue to use roughly the same figure of about 1 to 1.5 million for the number of individuals in this country who have asymptomatic HIV infection. That's just a guess, of course. Nobody knows for sure. But it is estimated that based on current rates that about 1/3 of these people will develop overt AIDS within 5 years. We're now moving toward 500,000 people with total AIDS cases in this country, and our expectation is that all these individuals, of course, will die from AIDS itself. It's important to look at the risk groups, though, who gets HIV infection, and these percentages have changed a little bit over the course of the infection. 54% of patients with HIV infection are homosexual or bisexual men. 24% are IV drug users. 6% are both homosexual and IV drug-using males. 7% are the heterosexual partners, usually women, of HIV-infected individuals. 2% got the infection from blood transfusion, and 1% are hemophiliacs. One change we've seen is a gradual decline in the number of homosexual individuals with this infection, largely due to intensive education efforts in the gay community. Unfortunately, we've seen a gradual rise, though, in the number of IV drug users with this infection, and we continue to fail miserably, I'm afraid, with dealing with these individuals and with that particular route of spread of the illness. We've seen a shift here as well. Currently, roughly 88% of AIDS patients are male and 12% female. Just 3 years ago, though, it was almost entirely a male illness and gradually spreading more and more among women. If you look at ethnic distribution, 51% of patients are white, 31% African American, 17% Hispanic, and less than 1% Asian. But what you'll notice, though, is that the black and Hispanic percentages are greater than the representation of these groups in our society. So a special effort has been made in many black and Hispanic communities to deal with this epidemic. 88% of AIDS patients are between 20 and 49 years of age. 1.5% of AIDS patients are children up to age 13. This is, of course, one of the most tragic aspects of this illness. Primary spread of the infection is where we started, basically homosexual activity and IV drug use. What began to occur after that is what we've come to call, or what epidemiologists call, secondary spread. That is, the sexual partners of IV drug users and bisexual males. And of course, many of these are female, and we're clearly into that phase now. The phase that people are still concerned about and very fearful of is what's called tertiary spread, and that's the heterosexual to heterosexual, where neither sexual partner is either an IV drug user or has engaged in homosexual activity. And we seem, unfortunately, to be moving into this phase of the epidemic at this time. Here's how you don't get HIV infection. The myths of transmission. You don't get it from toilet seats. You don't get it from telephones. It's not an airborne infection. We already said casual social contact is safe. It's not foodborne. You don't get it from mosquito bites, although there was some concern in Glades County, Florida, about that possibly occurring some years back. To be named later simply means that the Centers for Disease Control in Atlanta has been so incredibly circumspect in so many of their comments about this illness, and in many ways that's understandable and admirable, trying to keep hysteria down. On the other hand, using such formal scientific language sometimes leads to the implication, though, that not all information is being disseminated, and lots of patients, unfortunately, or people, unfortunately, read into that there are things they know that they're not talking about, or that there are other ways of getting it that aren't being disclosed, and so that continues to be an area of fear on the part of lots of people. I won't spend a lot of time here, but there are basically two tests that we use to test for the illness. The ELISA is the one that is used for initial screening typically. ELISA stands for Enzyme-Linked Immunosorbent Assay. And what the ELISA does is to detect the presence of HIV antibodies in the blood. And I won't go into any more details about it because of time, but if a person has a positive ELISA, this is then followed up by the Western blot. And the Western blot simply is used to confirm a positive ELISA test. And what it actually does is to separate and identify then individual HIV antibodies. And a positive reaction in both of these is supposed to indicate actual AIDS infection, although the case in Georgia we all heard about just a couple of weeks ago of a woman who just recently sued successfully for a false positive gives lots of laboratories and physicians certainly concern. The worried well is terminology conferred on people who belong to high-risk groups, people who participate in high-risk behavior, promiscuous sex, or IV drug use. And we see lots of predominantly anxiety-related symptoms in these individuals from time to time, episodic panic attacks, GAD sorts of symptoms, obsessive-compulsive symptoms, and hypochondriacal symptoms. So these make a lot of sense because of the worry about, was I infected with this activity? Could I get it from doing this, or did I get it from doing that? All sorts of preoccupation with physical symptoms as perhaps being an early sign that I've acquired the illness. We're interested, of course, in how people with HIV infection deal with this illness. We all remember Kubler-Ross from years ago who talked about stages of dying. And there are some similarities between Kubler-Ross's dying stages and HIV coping. The way people cope with HIV infection is the way they cope with any other major stress in their life. That is, there's tremendous individual variability. One's own coping skills, personality makeup, previous experience with crises, basically the way you've handled tough times in the past predicts how you handle tough times in the future. And so importantly, social support system. The social support system literature has exploded in the last 10 years in cancer and myocardial infarction, a whole host of disorders that shows how strong positive social support can confer a protective effect and a strengthening effect on coping with any kind of life-threatening illness. But having said all that, we can still say that there are a few predictable stages most patients go through. First, that of shock, which is basically numbness or disbelief that this has happened to me. Guilt does seem to be ubiquitous in HIV-infected individuals. Guilt coming from a number of possible sources. The feeling that somehow this infection is a punishment for the transgression of being gay or the transgression of being an IV drug abuser in some fashion. Even well-adjusted gay individuals who seem to be psychologically comfortable with their sexual orientation begin to ruminate, saying, if I were not homosexual, I would not now have a life-threatening illness. So their previous comfort with their orientation now becomes ego-dystonic and becomes a source of guilt for them, potentially. Concerned about having exposed loved ones to the infection, that one's lover may come down with the illness now because you've come down with it, and guilt often becomes focus for psychotherapeutic management. Denial, of course, we think of as being that largely unconscious psychological defense mechanism by which we disavow the painful aspects of any frightening or threatening event, and many of these patients go through various stages of denial. We've come to respect denial a whole lot more in the last few years, especially from the consultation liaison literature, as we've seen how protective denial can be from MI and from cancer, illnesses like that. So in some forms, denial is not only okay, but even adaptive. But denial, unfortunately, can also take the form, though, of self-destructing acting out, though, with sex, drugs, other risky behaviors as a way of pretending I'm not sick and kind of proving that I'm not sick. And this, of course, runs the risk of exposing other innocent people to this illness. Bargaining, I'll be a missionary to Rwanda if I don't have to die from this illness. The notion that I'll kind of magical thinking somehow there may be certain things I can do that will help me be the first person in the world not to die from this illness. Panic attacks, we've mentioned depression, and hopefully, of course, and often with our help, to get down to the last stage of acceptance somehow of their fate. A few comments about suicide and AIDS. Suicide and suicidal behavior is clearly increased in HIV-infected individuals. Men between 20 and 59 years of age with AIDS are 36 times as likely to commit suicide as age-matched men in the general population, and 66 times as likely as in the entire general population. That just means it occurs a lot, basically. The typical AIDS suicide is an unmarried white homosexual man who's 37 years old, who has known the diagnosis less than 6 months. It's interesting that a high proportion of AIDS-related suicides actually occur in institutional settings, in hospitals. They're often very sudden and impulsive behaviors, and this raises at least the possibility that delirium or some sort of dementia may be a precipitant in some of those cases where a person's judgment has been impaired by CNS infection with the virus. Also, some writers have commented that there may be two particularly vulnerable periods where we want to watch or be vigilant about suicidal behavior in AIDS patients. The first is right after the diagnosis itself is made because of the psychologically devastating effect of that diagnosis and the impact on the patient. And the other is much later in the course of the illness when dementia, delirium, and other CNS complications have come along, and the impairment of judgment that often comes with that may predispose to suicidal behavior as well in many patients. A lot of people have debated about whether or not every AIDS patient should see a mental health professional in this time of managed care. The answer to that more and more often is no, for a number of economic reasons. But if there is a comorbid psychiatric diagnosis in an HIV-infected person, the wisdom of psychiatric consultation is greater because primarily, among other reasons, of the increased suicide risk that occurs in those individuals. Another debate or area of discussion we often hear is how difficult it may be for a mental health professional or other physician to talk an AIDS patient out of suicidal thinking, to keep him or her from killing oneself. The notion that, gosh, if I had AIDS, I think I'd want to take my life as well. There may be some justifiable component to suicidal behavior in these individuals. There are a number of reasons to dispute that sort of thinking. We'll talk about depression in AIDS patients in just a moment, but we should always remember in any life-threatening illness that lots of suicidal behavior and thought and activity is a symptom of a treatable illness that we could call depression, and that many people, of course, once treated from their depression, even if still facing a life-threatening illness, no longer want to take their own life and are willing to let that illness take its course. There are other reasons, of course, to intervene in suicidal patients so that they can rationally evaluate the number of choices they still have to make. They have financial, business, and other life planning that they need to do, their family relationships that still need attention, and so a number of ways for us to comfortably justify helping our patients with their suicidal thinking. There are a whole host of ethical dilemmas when it comes to the HIV epidemic, and we could spend almost a whole talk just on this. Let me just pick out two or three that particularly deserve mention. The first is that it's becoming clear that we psychiatrists and really all physicians have a Tarasov-like obligation to warn potential victims of HIV-infected individuals if, of course, we know them by name. Unfortunately, what often happens is that our patient tells us, yes, I'm sexually active, and we have no way of knowing with whom. But if they're in a committed relationship and we know of that and they have not informed that individual of their HIV-positive status, we are potentially liable, at least that's been the case in some states, if we don't take steps to inform or warn that individual. Of course, all kinds of issues about confidentiality. We talked a little about the suicide issue. Mandatory testing we seem to be beyond at this point. All kinds of issues about life-sustaining activities, prolonging interventions, and so on. The false positive case 2 weeks ago in Florida in the media. So a whole host of issues that have been brought about by this epidemic. We also know that it's difficult for physicians who take care of AIDS patients. Here are just a few things that they have to deal with. You've got a helpless feeling and a helpless situation. Most physicians like to take action. We're attracted into medicine because of the desire to conquer illness, even conquer death. And here's an illness that's not going to succumb to that mindset. The inevitability of death and inability to alter that outcome is awfully tough for some physicians to accept. Homophobia, even in individuals who consciously say, I'm comfortable with a gay lifestyle, I'm comfortable around homosexual individuals, varying degrees or varying unconscious levels to that alleged comfort, and even unabashed homophobia that can come between a physician and a patient that would interfere with the care of that patient. AIDS phobia, very common. Have a couple of infectious disease physician friends who confide that often they'll find themselves washing their hands rather vigorously, even when just talking to AIDS patients, knowing it makes no logical sense, but it has a psychologically comforting quality to it. Grief reaction to patient's death. Part of the issue here is that so many AIDS patients are young. It's easier, of course, for us to accept, I guess, the death of someone who's perhaps 80 years old, lived a long, successful life, but when your patient is 28 years old and just beginning his or her career, the grief can affect us. Issues of the full court press, when to really go all out and do everything you can, or when to back off, or even to quit. The burnout that's been described when you take care of lots of these patients, the emotional drain on taking care of them, and some of the legal ethical issues we talked about too will take their psychological toll on physicians who take care of these people. And these often are not the most delightful patients to take care of either. They often refuse treatment. They don't take their medications. They may want to sign out of the hospital or stop seeing you altogether. They can be hostile and belligerent with staff. The ones that come to my mind, we've admitted to our inpatient unit in the past few years, came in often spitting and threatening to bite and cursing and so on. And these behaviors, of course, don't endear them to your nursing staff and other individuals, and that becomes another obstacle, of course, to taking care of them. These three aspects of AIDS also make this illness rather unique. It's hard to think of other illnesses where you can say this illness is invariably fatal, that every patient that gets this illness is going to die from it. Now, this is AIDS itself. HIV spectrum, we said there are varying degrees of progression there, but once AIDS itself is diagnosed, the patient typically is going to die from that illness. Also, the patients are so young, and we've already commented that being young often, especially with young residents or young physicians being so close in age, can create stresses and strains. And then I can think of no other illness, at least in our time, where the patients have been stigmatized, often called the new lepers, parallels made with leprosy and the plague in the Middle Ages as HIV infection has been viewed in our society. But again, all these sorts of things make it difficult to care for these individuals. Our society went through, of course, a hysterical phase in terms of reacting to this illness. I think it's died down somewhat now, but this is still the context, though, in which many patients are treated and taken care of, and they're very aware of how society feels about them and how society fears them typically. Another thing we know in our business, perhaps better than anybody else, is that what's real is not nearly as important as what a person thinks is real. Or another way to put it is that perception of risk or perception of reality is more important than reality itself. And so this is important when it comes to people taking care of AIDS patients. If nurses, residents, or we ourselves perceive ourselves to be in danger or to be at risk in taking care of an AIDS patient, even if the actual risk to us is small, that perception of risk is going to make us anxious, distancing from the patients, and become a problem in taking care of them. So these things need to be talked about on inpatient units or in outpatient clinics so the potential deleterious effects can be minimized. If we look just a little bit at some of the functional psychiatric disorders that occur in these patients, first of all, any functional, and here again I hate to use the word functional because we now, of course, think of all major psychiatric illness as having a biological basis, but by this I mean basically adjustment disorder and major depression without an obvious organic cause. First of all, it can be a new condition or it can be an exacerbation of a pre-existing psychiatric disorder. Adjustment disorder with depressed mood, anxious mood, or mixed features is probably the most common diagnosis that we give to these patients in the psychiatric realm. It's interesting that adjustment disorder is more prevalent in ARC patients than AIDS patients. And a couple of studies have talked about this, and the speculation is that ARC patients have evidence that the illness has clearly progressed, but they haven't gotten to the end yet. It's kind of like waiting for the other shoe to drop. They know that they're getting sicker, but the end is not in sight, and that twilight zone, that limbo state, is very, very unpleasant and uncomfortable for many of them to tolerate, and so their psychiatric morbidity is significant. And I mentioned that many ARC patients actually experience a reduction in psychiatric symptomatology once AIDS itself is officially diagnosed. We've already mentioned, too, that anxiety disorders are common across the whole spectrum of HIV illness, panic attacks, GAD-like symptoms, OCD-like symptoms, and so on. Major depression in these patients definitely occurs, but it's difficult to diagnose because we often rely on the presence of endogenous or vegetative signs and symptoms to make this diagnosis. We're looking for weight loss, appetite, energy change, and so on. Well, of course, in these patients, those kinds of biological symptoms may be caused by the HIV infection itself. So it's often tough to know, is this coming from depression or is this coming from HIV itself? Despite this difficulty, some writers have said that around between 15 and 20% of AIDS patients will meet criteria for major depression. It certainly can coexist with organic mental disorders. Manic episodes also occur. Here again, oftentimes organic causes for them, but mania and depression both being present. This has been a very controversial and very important study in the history of the AIDS epidemic. It was done by Igor Grant, who's a psychiatrist in San Diego, and published in the American Journal of Medicine in 1987. And he looked at subtle neuropsychological impairment in people with HIV infection. And not surprisingly was the fact that 87% of patients with overt AIDS had evidence of neuropsychological impairment. It was a little bit controversial and surprising that 54% of ARC patients also had evidence of neuropsychological impairment. But the big surprise in this study was the fact that 44% of the patients who fell into the asymptomatic seropositive group had subtle, fine evidence of neuropsychological impairment. Again, this was not overtly or grossly apparent at all. It was only with very, very sophisticated neuropsychological investigation. This has been an important study for a variety of reasons. On the one hand has been the feelings of most people to prevent discrimination against individuals with HIV infection, to still protect their ability to work and make a living and go about their everyday life. But on the other hand, what if this individual here were to be an airline pilot or to be in a sensitive job of some sort where there's no evidence of any physical or psychiatric symptoms at all, but slow, subtle, gradual progression of neurologic cognitive dysfunction? Let me make a few comments about AIDS dementia. AIDS dementia is one of the conditions that might bring an HIV-infected patient to the attention of a psychiatrist, of course. This is a common diagnosis in this epidemic. It affects at least 50% of AIDS patients, and some studies suggest 60, 65%, so an awful lot of them will have this. We call it AIDS dementia. In fact, we're really talking about a viral encephalopathy in actuality because the virus is in the brain tissue, and we call it dementia because it often doesn't have some of the more flamboyant features of overt encephalopathy or delirium, even though that's actually what it is. But it's the dominant aspect of the illness for many patients. We know now that AIDS dementia comes from the virus itself. In fact, there's lots of evidence that the HIV goes directly to the brain early in infection. The brain apparently is a very fertile breeding ground for the virus, and it goes there early on, and the virus has been cultured from the brains of affected patients with AIDS dementia. Diagnosing AIDS dementia early on can be difficult because the early symptoms can look like reactive depression.
Dr. Billings' remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 23, Number 23, returns to Charles K. Billings on Neuropsychiatric Aspects of AIDS.
Early on, you may not see much cognitive dysfunction at all, but rather malaise, withdrawal, trouble concentrating, the patient being kind of slowed down, and the presumption is this person is just simply depressed. They're a little apathetic and depressed, maybe some mild memory impairment, but nothing real dramatic early on. But what happens as some time passes, though, is the development of motor symptoms, and these typically will occur after some of the cognitive symptoms. Examples include unsteady gait, leg weakness, lack of coordination. The course then often picks up speed. You get moderate to severe global cognitive impairment as time goes on, psychomotor slowing. Patients are arousable and alert, but often have a vacant stare, very little spontaneous verbal or motor behavior. Different episodes of overt delirium can occur, episodes of psychotic episodes, agitation, manic episodes we mentioned earlier. Terminally, these patients can exhibit near or absolute mutism. Lots of other motor abnormalities. I won't go through the whole list. You can see ataxia, weakness, paraplegia, hyperreflexia, incontinence, and often at near death, these people are immobile, mute, and lying in their own feces and urine. So it's a very, very painful and miserable way to die. The cytomegalovirus inclusions have been found in the brains of many of these patients, and early on we thought that AIDS dementia was actually caused by CMV, but that is no longer thought to be the case. It's the HIV that causes it. Here are some of the laboratory findings you typically see in AIDS dementia. The CAT scan will show cortical atrophy and ventricular enlargement. The EEG often will show bilateral, non-focal diffuse slowing. Again, evidence that this is a viral encephalopathy, a typical manifestation of delirium. The spinal tap will show increased protein and sometimes a mononuclear pleocytosis, and the MRI will show white matter abnormalities. And this is best described actually as a subcortical dementia, AIDS dementia is. Just a few other comments about some other neurologic findings in these patients. Any kind of focal brain abnormality, of course, will often show up with lateralizing or localizing symptoms. They can present with seizures or the focal neurologic deficits I just mentioned. If infection is the cause of a focal brain abnormality, toxoplasma is one of the agents at the top of the list. Toxoplasma, in fact, is the most common cause of brain abscess in these patients. Cryptococcus, the second most common. A number of cerebrovascular accidents will occur also and can set up focal neurologic deficits that can lead to seizures or other lateralizing signs. Cryptococcus, the most common cause of meningitis in these patients. Here's another thing that's very important to keep in mind, especially if you're a consultation liaison psychiatrist. There are lots of non-specific factors that will have an impact on the mental status of an AIDS patient. Dehydration, of course, will affect concentration, alertness, hypoxemia, metabolic dysfunction, anemia, and then here, the use of antibiotics, antifungals, antivirals, and a whole host of chemotherapeutic agents are all substances, of course, which can have neuropsychiatric side effects and affect the patient's mental state. So we certainly need to be aware of those. If we get down to treatment of AIDS, as everybody knows, there's no treatment currently for the underlying immune deficiency itself, and we already mentioned that our treatments basically are supportive. We use chemotherapeutic agents, we use radiation for the malignancies, and we use different antivirals, antifungals, antibiotics for the opportunistic infections, but these are palliative only, don't get at the underlying immune deficiency. AZT, of course, is still the most widely used agent to slow down the progression of this illness. AZT, along with other agents, is a reverse transcriptase inhibitor, and reverse transcriptase is the enzyme that's necessary for this virus to replicate. So by inhibiting that enzyme, you slow down the replication. And there have been some improvements even in some of the psychiatric and neurologic symptoms with the use of AZT. Just a few, I think, real common sense suggestions for the psychotherapeutic management of AIDS patients. Number one is the notion of following the patient's lead. I think all too often, especially younger psychotherapists or naive psychotherapists may have the notion that he or she needs to go in and help an AIDS patient deal with his or her death or talk about the meaning of his or her life, very weighty sorts of subjects, and the patient may much prefer to talk about baseball or fishing or what's on TV tonight. So the notion of following the patient's lead, not kind of self-righteously deciding what's important to deal with, but letting the patient tell you, being available, being accessible, being accepting, that consistent availability, which of course contrasts with so many other people in his or her life very rapidly backpedaling away from them, is a very, very healing sort of behavior on our part. The control literature, especially in CL psychiatry, is very, very important. Anything we can do to help patients feel that they have some control over their environment seems to have an alleviating psychiatric effect, whereas if they feel that they're victims or they passively have to take whatever comes their way, it's a very uncomfortable feeling. So anything we can do to enhance a feeling of control is a specific intervention. Awareness of psychosocial roles other than that of AIDS patient. It's very understandable that once you acquire an AIDS diagnosis, you become an AIDS patient and nothing else. But if we can help these patients realize that they still may be a son, they still may be an engineer, they still may be a brother, an uncle, a neighbor, other psychosocial hats to wear, that this can be a way of diversifying and taking some of their preoccupation off of the AIDS diagnosis itself. We talked about how common guilt is, dealing with guilt feelings, constantly being aware of the risk of suicide, the potential for suicide, Always assessing cognitive functioning. We talked about how subtle this can be at first and how it can sneak up on the patient and you, and to be aware of that early on so that you may help the patient before they start to make perhaps some financial decisions that they might later regret. Just a few more features: be supportive and non-judgmental. Make sure that whatever works or whatever is available in your community the patient has access to. Always being alert for neuropsychologic dysfunction. We talked about grief, denial, guilt, anger, being aware of them. Projecting an appropriate degree of hopefulness, being aware of and utilizing whatever community services are there, and of course often helping the family that's having a tough time with this as well. These are all pretty straightforward. Again, frank, open dialogue, being up on the literature, just simple education, so important for many of these patients so that they will know what's available to them, and not being afraid to talk about life support issues as well. Now, what about the family? Let me make a few comments about HIV families, because we've tended to ignore families in this whole epidemic. They have the fear of contagion. A member of their family has a dreaded infection that's in the papers every day, and they worry about getting it because they have much more intimate contact than anybody else in this patient's life. They need lots of information. In my experience, they can't get too much information. They need some honest information about prognosis to help them deal with what's going on. Here's one of the dilemmas that family members so often find themselves in, being caught between, on the one hand, the desire to support and love, versus, on the other hand, the fear of contracting the illness themselves. And so you have approach, avoidance tied up right in that dilemma. Of course, for lots of families, lifestyle disclosure becomes an awkward or embarrassing component of this illness, that it wasn't until the diagnosis of AIDS that they became aware of the fact that their brother or son was gay or was promiscuous or used IV drugs or whatever. So you've got this superimposed on the illness itself. Helpless feelings, the notoriety, of course, the family on the street that has an AIDS case in it and so on. Keeping it a secret for fear of social ostracism. And of course, despite all this, somehow helping them to appropriately grieve is a big part of what our job is. Let me make just a few comments then about psychopharmacology with AIDS patients. I think it's helpful to think about the use of medications in these patients, psychiatric medicines especially, as being similar to the sort of guidelines and approaches that we would use in taking care of geriatric patients. What this means is that usually lower doses are necessary and indicated. Medicines may not be as responsive as they would be in younger patients. There may be a higher incidence of paradoxical reactions. And again, don't forget, we're dealing with basically a mild delirium, a brain that has a virus in it. It's not functioning properly. So you can see how that's a setup then for a number of paradoxical sorts of reactions. Anticholinergic side effects we want to avoid, so you take that generic caveat and apply it across the spectrum of psychotropic medicines. That means that when you come to antidepressants, we want to stay away from tricyclics that have anticholinergic side effects. If we look at antipsychotics, stay away from those with anticholinergic side effects. What anticholinergic side effects do, of course, is to worsen CNS functioning. We've known this for years. Can potentially lead to the spread of candida in the mouth and in the bronchial tree, especially because the dry mucosa may serve as a fertile ground for candida and other sorts of fungus infections. Here are a few recommendations when you look at the treatment of depression in AIDS patients. If you're going to use a tricyclic, desipramine is probably the best choice, mainly because it's the least anticholinergic of all the tricyclics. And Frank Fernandez in Houston's talked about in using desipramine starting low, like 10 milligrams a day, and gradually increase it in slow increments. Ritalin has been written about quite a bit, methylphenidate, starting with 5 milligrams twice a day and going up. Lots of AIDS patients can respond to Ritalin. It has no anticholinergic properties, no sedating properties. You're not concerned about the problems of addiction, so this may be a good choice, working, of course, faster than antidepressants as well. We'd want to be careful about using bupropion or meprodoline simply because of the high prevalence of focal abnormalities in the brains of these patients that would predispose them to seizure activity. So these two antidepressants do seem to have a marked effect on the seizure threshold, so probably are not good choices. The SSRIs are being used more and more in these patients because of the obvious reasons. Their side effect profile is so nice and clean. You don't have anticholinergic effects, you don't have cardiovascular effects, you don't have sedation. So that has led to their growing popularity in the treatment of depression in these patients. Again, low-dose strategy with any psychotropic medication, even if you use, say, fluoxetine, the notion of maybe starting with 5 milligrams or 10 milligrams a day and gradually going upwards, certainly true with tricyclics. If you're looking at neuroleptics, the high-potency, low-dose ones, like a milligram or two of Haldol, just like you would with delirium in the hospital, is a good starting place. If you use benzodiazepines, the short half-life benzos like Xanax and Ativan are probably better choices just because they're not going to accumulate like the ones that are longer acting. And always be on the lookout to exacerbating delirium, because as we said, this is already a mild delirium to begin with, and we don't want to make it worse. Just a couple more points and we'll be through. Just to be aware of support groups in your community. We can't take care of these patients all by ourselves, certainly, and even a nice collaboration between physicians and nurses and family often can't do what meeting with other individuals who have this illness also can do. Now, be aware that some patients early on are going to be reluctant to be a member of a support group, because the last thing they want to do is to be around the depressing company of other people that have the same illness they do, and they may not want to, and certainly we would respect their wishes, but like in any other situation, periodically recommend it to them in a gradual fashion. So it may be too frightening for them to do it at first. These groups, though, can help a patient resist the tendency to remain isolated, which is built into this infection. One thing about groups, and social community-based groups especially, is that they should be open-ended so that attendance can be intermittent if so desired. This notion of having a group that's restricted to 8 members and you're supposed to go every single time, and if you don't come then you're kicked out, is not good for these people. The ability to drop in and out probably works better for them. And of course, groups are a way to disseminate accurate information about the infection. They can see people, of course, express appropriate feelings about this illness, and can even start to participate more actively in their own treatment as they have role models. And then lots of these groups, of course, focus an awful lot, too, on diet, rest, exercise, and relaxation. And these are all clearly very, very helpful in these patients. Might have just a few moments for any questions or comments. The question was, what do we know about the current degree of contagion of this illness? If you are in a relationship with an HIV-infected person, how likely are you to get it? Of course, the first thing is that you're only going to get it from blood or semen. So that's the first thing, is that even drinking out of the same water glasses and so on doesn't seem to be a problem. What this often comes down to is condoms. How protective are condoms? And I don't know what to say about that. I read all the same literature that everybody else does, too. Theoretically, a well-made condom is supposed to prevent this virus from getting through. But you have cheap companies that make them. You talk about ones that are damaged. I think you have to consider that the risk is always there of becoming infected. And what lots of couples have done where one individual is HIV positive is to engage in what they have agreed upon is safe sex behavior between the two of them that doesn't expose one or the other of them to bodily fluids. Now there again, when do you stop and so on? But the risk is always there. It takes one viral particle, one viron, of course, to pass the illness along to another individual. And yet, on the other hand, if you talk to PWAs, persons with AIDS, what they'll say, though, is we're supposed to now become monogamous. We're supposed to live now for 2 years without any sexual contact, without any affection, without any intimacy. You have to, on the one hand, balance the risks to an individual who's not infected with the right to as full a life or enriching a life as one can have in the time that one has left if you are infected.
John J. McCarthy spoke on opiate withdrawal on your last issue of Audio Digest Psychiatry, and Dr. McCarthy, who's director of Bi-Valley Medical Clinic, Sacramento, an associate clinical professor at University of California, Davis, returns to this issue to summarize some alternative approaches to opiate addiction, beginning with drugs other than methadone.
There are a couple of new opiate medications that are going to be available. The first one is LAM, levo-alpha-acetyl-methadol, which is a longer-acting oral opiate medication. In some way a cogener of methadone, except LAM is a prodrug. LAM is not an active drug in itself. It has to be metabolized in the liver into an active drug. Orlam is the brand name. It's not available in California. The state regulations are so incredibly complicated that we may not have this drug for another year. It is available in other states that don't have the amazing bureaucracy we've put together here. LAM is not going to replace methadone, but it's going to be of advantage to, I think, rapid metabolizing patients who don't stabilize well on methadone. It's going to be of advantage to patients who cannot make it into facilities 7 days a week like is required for patients starting on methadone. So special clinical situations, it will have some advantages. Buprenorphine has been shown to be as effective as methadone in the management of narcotic addiction for maintenance, and some research is being done on it. I don't expect it to be available in any way in the near future, but maybe down the road if we identify, as we have with LAM, that it might serve a special population or serve a special need, we might have buprenorphine available. Heroin maintenance is going on in England. It's not going on a large scale because methadone is clearly a superior form of public health treatment of opiate addiction, but what about the addicts in the street who don't want methadone? And there is a major move in Switzerland and in Germany to experiment with heroin maintenance to manage the street addict population, those addicts who do not choose to come into methadone programs. So you're looking at heroin maintenance really as a public health strategy, as an AIDS and infectious disease prevention strategy, as a management strategy. We had morphine maintenance clinics in the 20s after the Harrison Narcotic Act went through. We had a large number of addicts who were maintained by physicians prior to that. And there was a model clinic in Shreveport, Louisiana. Morphine maintenance can be done. I've talked to English physicians who are using heroin maintenance, and they tell me that heroin maintenance can be done for years and years safely. At times the doses they're using are quite high. The physician John Marks in Liverpool is using 200 milligrams 4 times a day of heroin to maintain some addicts. The idea with this approach is that these patients, street addicts, will eventually move into methadone and then from methadone maybe into drug-free situations. That is, you have a continuum of services trying to reach this population. And in fact, if you look at drug use, it tends to diminish with time. The worst drug users are the late adolescents and the young adults. And gradually they mature and they use less drugs. And the issue is to keep them alive and keep them uninfected. So we do need to think about these alternative strategies. Addiction treatment is really a very important part of public health. Sort of used to be separated off. We did methadone, and there was this hepatitis stuff, but no one got real excited about it. AIDS changed that dramatically. AIDS made methadone treatment and addiction treatment a very important part of an overall public health strategy. So at times you're in dilemmas like around needle exchange that would have been unthinkable in addiction treatment 10 years ago to consider needle exchange strategies. We wanted abstinence, giving them needles, but after watching the spread of all these infectious diseases, there are 6 different viruses spreading in IV drug use populations. You've got hepatitis B, C, and Delta. You've got HTLV1 and 2, and you've got HIV. Then you've got all the bacterial infections. Then you've got the TB, which is really another spin-off of drug use, and the spread of HIV related to IV drug use, and HIV-positive patients being more at risk for TB. No public funding for TB. It all went into criminal justice, and so we didn't track these people. We didn't treat them appropriately. It really requires comprehensive treatment for this patient population, not just drug treatment. You have to provide medical care for these patients. A lot of them have no insurance, of course, or they have Medi-Cal cards, which are good for acute hospitalizations, and they can't find a physician to treat them. Psychiatric care is very important. The mental health system has been decimated in California, and of course, mental health patients untreated are extremely high risk for substance abuse. I'm a psychiatrist, and we have an active psych clinic in our facility. We have about 350 maintenance patients and about 70 or 80 patients in active psychiatric treatment, mostly for the treatment of depression, but a lot of them for the treatment of panic disorders and anxiety disorders, OCD. I mean, they have all the spectrum of psychiatric problems. Social support services, these are very important. We have certainly a homeless population that we're trying to manage. Just laboratory services, as I mentioned, urine testing is very important because, one, there's a tremendous amount of shame associated with drug use. And I think it's always seen as when addicts don't tell you the truth. They're just lying, they're just manipulating, they're just being antisocial or whatever. But we don't remember that shame over their behavior is frequently a part of why they don't want to tell you what they're doing. And I think laboratory services are important from that regard, not as a cop mentality, but as a medical treatment. Steve and I, Dr. Bhakti and I have been interested in quantitation of urine levels of drug. The drug war has this, either they got a drug in their system or not, that's all you want to know, either they're a criminal or they're not. It's really the only area of medicine where you're not concerned with how much drug a patient is doing. If you get a hematocrit, you don't want to hear, well, they got blood, they got some blood. Well, how much? And the amount of drug can be very important in terms of picking up very high-level compulsive users. And we've had some interesting success with benzodiazepines and urine drug level monitoring. Just a bit about a 21-day withdrawal program. This is not a cure, as I said, for opiate addiction. You don't cure opiate addiction in 21 days. But in this day and age, this is a very important public health modality, as well as a public safety modality. They have to have some treatment available, and of course, treatment is available for maybe 10 to 15% of these people. To get them a 21-day withdrawal is very important. You can educate them about AIDS. We do recycle them through this 21-day program. They're given education, they're given harm reduction education, because you know that most of them are going to go back out and they will relapse, they will continue to use. So we stress needles, how they manage needles. We stress them educating their peers. We have to get some kind of relationship with them about the importance of stopping the spread of these diseases. We're not going to do that by screaming and yelling at them and calling them names. They can serve as a vehicle to educate those that aren't in treatment about sharing needles and the problems associated with that. The Dutch have been world leaders in alternative strategies, alternatives to our particular kind of drug war approach. The Dutch basically realized that drugs cannot be eliminated from a free society. You can have an unfree society and maybe control it, but a free society with open trade and open travel, drugs cannot be eliminated. The Dutch know this. They have one of the world's largest ports, so trying to control drugs in Amsterdam, coming into Amsterdam, is not possible. What we have to aim for is reducing the harm that drugs do to society and to the individuals that use them. Abstinence is not necessary for improvements in personal and public health. This is important because part of the philosophy a lot of us grew up with is if they're using, I don't want to deal with them. Throw them out of treatment, throw them out of your office, because there's no point in dealing with someone who isn't clean and sober. Well, most of them cannot get clean and sober, or it's for periods, it's episodic. So you can make significant improvements in their health and secondarily in public health if you have some tolerance for this behavior that just doesn't magically go away by telling them to stop. Mobile methadone buses and needle exchange were responses to addicts' demands in Amsterdam for public health services. They wanted needle exchange because of hepatitis, because of the spread of hepatitis. And amazingly, the Dutch government actually listened to these addicts and actually responded by saying, well, okay, we'll try this. And they developed methadone buses because they have a NIMBY syndrome over there. No one wants a methadone clinic in their community. You would bring all these terrible addicts in. So the Dutch did develop this mobile methadone approach where the bus goes around and stops at different points in town. The Dutch have decriminalized use de facto. They have not changed their laws at all, but they do not criminalize drug use and possession. This is a social policy deliberately to increase accessibility to healthcare services. The issue is who's going to go after these people, the cops, or is it going to be a public health outreach? Who is going to access them? And if you send the cops after them, you really drive them underground and you prevent the public health from dealing with these people. The Dutch access about 80% of their addicts. We access about 15%. The drug war, as we fight it, really has some obstacles to treatment. One of them, of course, that it restricts the availability of methadone treatment, restricts access to overregulated clinics. The regulations on methadone programs are unbelievable, and they come up with new ones every day. And it only meets the need of a small percent of addicts. Physicians should be able to use methadone. I think they should be trained to use it, the general physician. I don't think it should be, well, just go out there and prescribe it. People could certainly be trained to use methadone, especially in rural areas where they don't have treatment programs and you can't set them up because the people go berserk. They tried to put a methadone program up in Humboldt County, and it really got almost life-threatening for the people trying to start the program. And they have a significant heroin problem up there. So physicians are forced to use polypharmacy to manage withdrawals that are managed more safely by opiate substitution. And obstetricians up in Reading had to admit pregnant heroin addicts to the hospital basically on a kind of diagnosis of a urine infection, and then put them on methadone, and then say that we cannot withdraw these women because that's contraindicated. Now, that got the DEA involved and the state methadone authorities, but that's the kind of obstacles to effective treatment that we have with our drug war. And when you prevent physicians from using the appropriate medication, well, who wants to learn about treating this problem? And the drug war has opposed research and development of new options. This is just some ideas about how we might approach things differently. One is to decriminalize. Italy is decriminalized, Spain is decriminalized, the Dutch have decriminalized. The English really didn't ever emphasize criminalization as a major part of their approach to drugs. It's really our thing, and it has failed. Putting people in jail, not only doesn't solve their drug problems, it creates a very angry person who leaves the jail situation and 5 minutes later is showing us and them and whoever else that they can't stop them from using. So it creates this adversarial, hostile situation. And it wastes an enormous amount of public resources recycling nonviolent drug users through the criminal justice system, taking their kids away, putting them in foster home. And of course the criminal justice system is soaking up all of the available excess money that our counties have. Our funding just goes down every year while criminal justice goes up. And most of these people going into the criminal justice system have drug problems. Medicalization is another kind of category of alternative response. Certainly methadone is part of a medicalization approach. Drug use, just a little bit about triplicate forms. I think triplicate forms have had a cruel effect of denying patients access to legitimate pain medications, undermanagement of pain problems, especially in kids and the elderly. Fantasies that, well, kids don't have pain, or elderly people don't experience pain the way other people do. And so undermanagement of pain is a major problem. I think the triplicate form stuff has a lot to do with this policy, and the physicians afraid to prescribe medicines because of fear of addicting people. I don't think opiates are in fact all that addicting. I mean, people who are maintained in burn units on high doses of narcotics for long periods of time and then withdrawn do not go on to become addicts. There's a couple of studies of 22,000 people on opiate management. 4 or 5 had addiction problems afterwards. I mean, the percent of people that are going to get into problems are very small, and I think like the benzos, these are addicts, whatever that is, but most people I don't think are at risk for, if they're treated properly for pain, of becoming addicts or opiate abusers. Legalization, I don't think society is at a point where we can discuss legalization until we understand the harms of the drug war. And I don't think society understands that yet. I mean, Surgeon General Elders, I think, made a courageous comment. There's an obvious association between prohibition and this illegal drug trade and crime and violence in our society. And to come out and just say that, yes, we are ignoring a major cause of crime and violence if we do not look at drug prohibition and the drug war and look at some alternative ways of dealing with this. Well, they wanted to send her back to Arkansas for doing that, but I think we do. We need to look at alternative strategies. But we need to really take a look at the harms that our policies are doing first, so that words like legalization really have no meaning. People have all kinds of fantasies about what it is. One of my fantasies would be, what if we had a small 10 or 15 milligram codeine available over the counter? I don't know. Would that be the end of society, or civilized society as we know it? It would certainly put a major dent in the profits of the drug trade. I think what we need to do is use our brains and start talking about alternatives. Europe is ahead of us in alternative strategies, and Australia is taking a world lead in alternative strategies. We can do more than what we're doing.
Thank you, gentlemen. Audio Digest Psychiatry is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1994.